So we are delighted to have a excited group this morning. We are here to cover and talk about the Geriatric Emergency Care Applied Research Network Advancing Dementia Care Updates. So this is 2.0. Many of you are familiar with 1.0. Today this is going to focus on dementia care. And we're going to just jump right in, even though it's bright and early, because we have 4 speakers, and so we have a lot of material we're going to try to cover, just so that we can really give you all a solid update on everything that's going on. Let's see. Maybe I'm just going to use the keyboard. Okay, so panelists today, we're very fortunate to include the executive committee from Gear 2.0. Chris Carpenter helped pull this together as an organized didactic, and we have Chris from WashU, and he actually represents, we have 4 work groups that many of you are familiar with, but he represents the communications group, and you'll hear more about that. We have Scott Dresden from Northwestern, and he represents the ED practices group, and we have myself at Yale. I will be talking about detection, and Manish Shah at University of Wisconsin. The purpose of this talk is really to give you all an overview of Gear 2.0, so that's again specifically focused around dementia care. We'll talk a little bit about the work that we've done with stakeholders. I think one of the key features of Gear is really engagement of all of the individuals that are, sit front and center and around geriatric and dementia care when it comes to emergency care for these populations. And then finally, the research priorities that these groups stated are important, and the funding opportunities behind it. Okay, perfect. So what is Gear 2.0? So Gear 2.0 really is focused, we're very fortunate to be supported and funded by the NIA, but its mission is really, again, to advance the science around how we can improve care for the population, specifically those with cognitive impairment or ADRD, Alzheimer's diseases and related dementias. And most specifically, the stakeholders, but putting front and center those individuals who have dementia and their care partners. It's a phased award, so during the first 2 years, the R61 phase, we focus on those 4 topic priority areas. And in the second phase, we just move forward and put our money where our mouth is and provide funding opportunities behind those research gaps that these stakeholders identified. These are all of the partnered groups. So it doesn't sit on one specific specialty or discipline, but it's a joint effort around multiple transdisciplinary efforts and also our partner organizations. And so we're very fortunate to work with not only other funders, but also organizations that include the Alzheimer's Association, representing persons living with dementia, and also care partner groups. This is a quick overview of the timeline of what we do during the first 2 years. So many of you are familiar with this process of pulling together the stakeholders to say what are those important research questions, conducting scoping reviews behind those. You'll hear more about those results. Pulling together a big consensus conference, which actually spans 2 days, to say, well, okay, we've heard what's out there, what are the gaps, and what are the priority areas now that we should really recommend research focus on. We then put forward funding opportunities annually, RFAs that address those priority gaps, make selections, and then we have cores that are going to be supporting a lot of those pilot studies that will be funded, because our hope is that these pilot studies will then move forward to larger scale multi-center studies that really generate high quality evidence around best practices for emergency care for persons living with dementia. This is an overview of our consensus conference. The first one, which many of you participated on in 2019, was in person over 2 days. This conference, because of the pandemic, we had to do virtually. And so it was a long 2 days. I think it was an exhilarating, exhausting, and exciting 2 days. And for those of you who did participate, we tried to make it fun. There's a purposeful blue behind this to have reminiscence of some sitcom shows, Brady Bunch, Hollywood Squares. But really what's important is the engagement of all different types of stakeholders in here. In this group of consensus conference participants, we had 5 persons living with dementia. And care partners, additional care partners participate, and they participated for the full 2 days with engaged discussions. We had breakouts, we convened, had summary discussions around what key points are. And some of those key points had a lot of overlapping themes that came out of the 4 groups. I want to highlight a few in here, and many of them, again, focus on the triad. I'm going to call it a triad because I think many of us in here are clinicians, but as clinicians, we have to also take into account the patient-centered and also the care partner or caregiver or family member-centered perspectives and what matters to them. And so as you read through these overlapping themes, you'll see that there's a big emphasis on the focus of what matters to them, how do we measure what matters to everyone else, and the communication, the engagement, the interprofessionalism, the trust that must come from all of this, and most importantly, how do we make sure that we're inclusive? So really taking into account also research that addresses those that are disadvantaged and also vulnerable. You'll hear this in the four work groups that'll be presented in and these overlying themes. So now I'm going to move forward and talk about the detection group, and here you'll hear a little bit more focus on that, and you're going to hear subsequently about the other three groups as well. As mentioned again before, the work you're hearing today is we're very fortunate to be supported by the NIA and also John A. Hartford Foundation and West Health Institute. So why dementia? And for many of you who might be interested in this, you're thinking, well, how does that intersect matter, and why does it matter in the emergency department? Well, what we do know is emergency care for older adults, especially those with dementia, is suboptimal, despite the fact that they use the emergency department more than twice as likely than individuals who don't have dementia. Unfortunately, in the emergency department, we often don't recognize these individuals when they have dementia. And there's a nice opportunity for us there to really recognize that not only can early recognition and detection of dementia improve or reduce the rate of cognitive decline. So we're not necessarily going to reduce their risk of developing cognitive decline, but we can reduce the rate of the cognitive decline. We can also improve their care coordination and, most importantly, patient safety. I often use the example, if you don't recognize that an individual has cognitive impairment and you send them home with extensive discharge instructions or a series of medications, this is the individual that's going to come right back to the emergency department. So for us, it is a safety concern. So what is the role for the emergency department when it comes to detecting dementia? What our work group convened and discussed was, well, when we focus on detection, what does it mean? What are the goals and parameter of our questions and the things that we should be focused on? We did not use age as a cutoff, and so the way we focused on this was to say we're going to exclude children. We did emphasize the fact that the ED's role is not to diagnose dementia, but to screen for it. And we also wanted to highlight that the terms cognitive impairment and dementia are often interchangeably used, but dementia itself is really a diagnosis. So when you search for cognitive impairment, because we wanted to be inclusive, you'll also see a lot of things come up around delirium. And delirium, as we know, is a transient decline or transient loss of cognitive or impairment of cognitive function, whereas dementia is chronic, and this is not one that's really reversible. So we excluded delirium after we searched for cognitive impairment. We identified our questions using the PICO format, so population, intervention, comparison, and outcomes, conducted our search, abstracted the relevant information from relevant articles, and then presented these findings at our consensus conference. The first two PICOs that the group we had, I think we generated close to 20 PICO questions, and you'll see those we have this now coming out in press. But the top two PICO questions focused on one, how can the emergency department best identify cognitive impairment? So best in terms of sensitivity, reliability, accuracy, and we also emphasized the need to look at differences by race or ethnicity, so do studies focus on that? And then the second question was, are there pragmatic cognitive impairment screens? So are there practical ways that we can do this in terms of easy to use, quick to learn, quick to complete? These are the flow diagrams of our scoping reviews, and for both questions, we completed extensive medical and health literature reviews, and those essentially boiled down to, for PICO 1, we searched over 1,400 citations and found 45 relevant, and for PICO 2, we searched over 2,000 citations and found 66 relevant. Of course, with these questions, there was some overlapping papers, and these are the findings. So for the most part, papers were English. We had some in French, but for the most part, those tools were English, and most of the patients studied were 65 and older. Because we were looking at papers that had accuracy, most had to have a gold standard, and the most commonly used gold standard was the mini mental state exam. Feasibility really focused a lot on duration and acceptability of the screens to the clinicians, And of the many, many screens and tools that were assessed, the 6-item screener had the highest pooled specificity and took about a minute to complete. The Ottawa 3DY had the highest polled sensitivity, and this was based on literature at the time. So during our consensus conference, we did a little bit more of a deeper overview around the discussion points of that scoping review, and from the discussions from the breakout groups, these were the top 5 voted priorities. And what you can see are by row, each of the top 5 priority questions, and then how the various groups rank them. So we broke the groups, the stakeholder groups, into ED providers, non-ED providers, and then individuals who identified as having dementia or their care partners. And you can see there's a lot of consensus and agreement in terms of what the number 1 priority question was, which is what is the best approach when it comes to screening for ED cognitive impairment. And this includes data-driven sources, screening tests for effectiveness, efficacy, and referrals, all the way down to the 5, which again, all very close, but top 5. What information is needed to differentiate between delirium versus undiagnosed cognitive impairment versus dementia? So this work couldn't have happened without the concerted effort of a large group of, this is just the detection work group, so we had many, many members, and I won't be able to cite all of them, but many, you may recognize many of their faces. And so again, wanted to thank you all. This is the detection group, and I'm going to now move this forward to allow Chris Carpenter to talk about communication and decision making.
Thanks. How do I advance? This one? Okay. So I'm going to just briefly talk about what we did in the communication and decision-making group. It's a pretty complex topic in terms of what do we mean by communication. Communicate what during a medical encounter? At what point in time during the ED course of care? And with what outcomes? What are we talking about when we talk about communication? And what do we mean with decision-making? We put this figure together to try to capture for the audience what the complexities are here at the level of the patient, the care partner, the medical team, and the system. But it is a complex endeavor. And you just think about what we already know about some communication in emergency medicine. Kirsten Engel at Northwestern, about a decade ago, published research showing that in young adults, like age 20 to 40, that 80% of them, after an ED encounter when they're discharged home, don't really understand their discharge diagnosis, their return precautions, the medications they're supposed to be taking. That's 20 to 40-year-olds. Now add on layers of complexity with dementia on top of that, and you can only expect that the situation is going to be worse, and that the communication is going to be less intense. I had a situation at WashU about a decade ago where I had a patient sign out to me early in the morning, 7 a.m., who'd been there all night after he had a head injury, no bleed, just a contusion. He was pending discharge home when he signed out to me, and I never saw the guy. He was out the door before sign-out was over. But about 7 hours later, he came back to the ED in police custody, and the story was this was an elderly gentleman who has dementia. We didn't recognize it. Nobody had screened him at our ED and put him in a cab, and he told the cab at some address that wasn't his address because he couldn't remember his address. Cab driver didn't know better, let him out, and fortunately, it was a warm time of year. This gentleman just went to sleep in somebody's front yard, and they called the police, and family, meanwhile, that day had been frantically looking for him all night, not knowing where he was. And so communication that covers a lot of area, because if we know that the patient has dementia at some significant stage, severe stage dementia, we might need to get the patient care partner involved in some of the decision making. And so this figure is our way of capturing some of those complexities that occur and what our group was looking at. Like Eula's group and the other groups, we brainstormed some questions around the idea of communication and decision making. We came up with 16 questions, and most of them had a lot of overlap with care transitions, and we ended up ultimately focusing down really on communication-focused ideas. Does communication and decision-making differ for persons living with dementia from those without dementia? What do we know about the differences? And are there specific strategies that we can use, like teach back or next day follow-up phone calls, that actually improve measurable outcomes of communication in persons living with dementia? We also had 2 scoping reviews and actually went through about 12,000 papers, because communication is such a broad term. and ultimately did not find a whole lot of research published in the area of ED decision making. We did find a spattering of studies across mostly Canada, Europe, Australia, and the US, where some are surveys of staff in the hospital, some are surveys of patients, some of them 30 years ago by Art Sanders and the folks that published that series of articles in Annals of Emergency Medicine. There's a pretty consistent signal among older adults and their care partners that they feel in the ED communication is rushed, that we don't spend enough time. Kirsten Ingalls had shown that about 75% of our time in the ED is spent not with patients. It's on computers, it's documenting, it's making phone calls. That pushes over into what patients perceive as the quality of their care, and it does impact their patient satisfaction scores, where they feel that their care is less valuable in the ED that does not spend the time to communicate with them. They also feel that the dyads, that the care partners need to be involved, and often they feel neglected, and that was a pretty consistent signal. There's also some interesting findings about discordance between healthcare teams, that the emergency medicine team doesn't necessarily tell the patient and the care partners the same thing as the inpatient team, which is not the same as the primary care team. And so communication might not involve necessarily the patient or care partner at all, but physician-to-physician communication, which is something we hadn't considered. There wasn't a lot of accommodations for non-English speakers. In fact, looking with the lens at diversity, equity, and inclusion, there isn't much reporting on DEI at all in this body of research. So we really don't know much about how inclusive either the surveyed populations of physicians and nurses are, or what the ethnicity, the gender identity, et cetera, of the patients that are enrolled are, because it's just not reported. So after these scope interviews, we then came up with 5 questions that we prioritized and then voted on at the consensus conference. These are the votes of the healthcare teams, the physicians and nurses, geriatricians, emergency physicians. And you see at the top are identifying barriers and facilitators of effective communication. And second vote was the valid and reliable outcome measures. The researchers felt that this was important. How do we know if communication is effective if we don't know how to measure it, if we don't know how to measure those outcomes? The next slide is going to show you the care partners and the persons living with dementia, they're voting. They didn't think that was as high a priority. They put that down towards the bottom of the list. So that was the difference between the healthcare teams and the patients. And then the next level was how do individual provider and system level factors influence communication, best practices for engagement of care partners in decision making, and how can each member of an ED care team ensure high quality communication. We had 2 persons living with dementia on our team, and actually one was a person living with dementia, one was a family member of somebody who's now deceased who'd had dementia. They had polar opposite opinions about involving the care partner. The person living with dementia said, don't ever talk to my family. I'm the patient. I'm capable of making my decision. The family member said, no, the family member always has to be involved, and they cannot be ignored by the healthcare team. It was interesting to see those 2 individuals passionately speaking about their polar opposite perspectives and realizing how difficult it is to appease everybody. So this slide shows you that the prioritization of the patient stakeholders. And they thought that number 2 should be how each member of the ED care team can ensure high quality communication. So I'd like to thank my team, some of whom are in the room today, without whom this would not have been possible. I think communication is a complex topic, and it does touch on all the other areas, but I think that it's a rich area for research as well, and hopefully we get some applications for this to study communication and decision making. And I'm going to turn it over to Scott, who's going to talk about best practices.
Thank you, Chris. So yes, I'm Scott Dresden. I'm at Northwestern University, and I was in charge of the ED Care Practices group. I think that as far as ED Care practices go, this is something that I think that we all, at least probably in this room, understand that the way we care for persons living with dementia in the emergency department, or the way that persons living with dementia are cared for in the emergency department more globally, is suboptimal. We know that stories like Chris tells of when sending patients home without having full understanding of their discharge instructions. We know that they stay in our emergency departments for too long and they become delirious. We know that we have a hard time controlling their pain and really understanding what their needs are, especially if they don't have a care partner present. So I think this was really exciting work to jump into. I will say, just like going through this whole process, it was a little bit overwhelming in trying to see like the broad scope of different ideas that had been put out there, and very disappointing to see the lack of any particular topic that had any depth to the research. So I think that there is great opportunity for this field, I think in all 4 of our work groups, but I think especially in care practices, because I think there's a lot of ideas out there, and we'll cover some of them, but all of these ideas that we talk about need to be probed further in depth. Here's my research support, and I don't have any conflicts of interest. This is our care practices team, and I think that the other speakers have highlighted that this has really been a collaborative effort, and having voices of persons living with dementia and care partners in this whole process really influenced the whole process. I think that the consensus conference was particularly enlightening to me. It was great to hear voices and saying and hearing experiences, but it was also really, really disappointing because everybody had their horrible emergency department story, and we all know. I think that all the emergency physicians in the room could completely identify with this is not surprising to me, unfortunately. And then you do your next shift and you walk into the waiting room and you just walk past the waiting room and you see man, this is just kind of how this is going to go. And so it was just really, really disheartening, but really, really helpful to have those voices with us. So we developed 22 questions, and like I said, it really kind of got to be a wide net that we cast. And these all went from how are their care needs different for persons living with dementia, how can we prevent incident delirium, how do we identify delirium in persons living with dementia, how do we use a behavioral pain scale or pain observation tools, how can we best interact with care partners while in the emergency department? So really a wide range of questions that we considered and brought forward to our work group to consider before the scoping review. So our final PICO questions were, what components of emergency department care improve patient-centered outcomes for persons with dementia? And how do emergency care needs for persons with dementia differ from other patients in the emergency department? Then we used persons living with dementia in our PICO questions, but as Eula mentioned, most of the studies that were out there include cognitive impairment rather than a clear diagnosis of dementia, so we ended up including cognitive impairment as as inclusion criteria. So that's a little bit of a limitation here. It'd be really nice to know, here are the best care practices for persons living with dementia. However, this is also more of a practical approach, I think, for us in the emergency department. Many times we don't have a clear diagnosis. We have a mention in the chart. We have a family member who says, oh, mom's, not been thinking well for the past 3 years. We know this is going on, but we haven't actually seen a doctor about it or talked to a doctor about that. And so I think using cognitive impairment might be a little bit more practical. So we performed one scoping review for both of our questions. We reviewed over 10,000 articles, and we included 49 when it all came down to it in our review. And so the key findings that there was through this is that there was a wide, not wide range, a wide range of studies on care practices with little depth or reproducibility. And I think that's the biggest thing that we noticed. When forming that PICO question, we really made them very broad, and we thought about this idea of components of emergency department care. And so really the components of care were anything that we do for patients living with dementia, and particularly anything that was done differently for persons living with dementia than for other patients. And so there was a lot of research about the pain AD scale. So pain assessment and management is clearly a very important topic in this field. Unfortunately, we really couldn't recommend the pain AD score. The studies that were out there didn't necessarily show that patients received any medications earlier. There was better documentation of pain scores for people when the pain AD scale was used. So that's probably the best thing that's out there, but there just wasn't enough evidence to say for sure that this is effective in improving patient-level care. Comprehensive geriatric assessment and a dedicated emergency department unit. This was a single study that showed that there was improvement there in outcomes. Keeping care partners in the emergency department. I think this was something that there was some qualitative research that said this is a great thing. We love having care partners in the emergency department. They give us more information. We can communicate better, but there wasn't anything definitive that this improved outcomes. Hospital care companions, so it's kind of a different idea where we had people who were part of the healthcare team who stayed with the patient in the emergency department and helped to mitigate any adverse events for that patient, help them, redirect them, keep them occupied, talk to them, that sort of thing. And that did show some significant improvement in outcomes. Delirium identification, there was a lot in delirium identification, but not any real clear recommendable approach. Fall prevention, there was an older study that failed to show any improvement in a fall prevention intervention for this particular population. Admission to hospital at home, it did show an improvement in some patient outcomes there, and so that's something that is particularly encouraging. That might be something that we can study further. Palliative care, there was a lot of information about how to engage palliative care, and that patients were receptive to it, but no clear patient outcomes there. And then changes to the physical environment in the emergency department. There were some really interesting, engineering approaches. This one approach of a non-contact monitoring system, and then what they called this like charity dome, where it was like a screen that kind of like decreased the stimulation for the patient while in the emergency department. It was a very preliminary approach, but anything to really decrease the stimulation, I think, seemed to be an important thing for patients. I didn't see any good robot cat studies, no.
Is there one coming?
No robot cat studies, but perhaps. As far as emergency care needs, so the big topics that came out of all of these were the behavioral and psychological symptoms of dementia. Seemed to really be an important thing that brought patients to the emergency department, and then also influenced their stay in the emergency department. Functional ability or functional decline seemed to be a big thing that brought patients to the emergency department. Pain, and then in this work that there was a lot of discussion of the difficulties with emergency department care, and these are all the things that we know and understand, but a lot of it is the behavioral and psychological symptoms. A lot of it is families and patients just really feeling dehumanized while in the emergency department and not having access to toileting and nutrition and hydration, and I think all of the things that we think about as far as geriatric emergency department processes, which are really important for patients and their families, really to feel human while in the emergency department. So these were some really interesting articles and again, disheartening articles to read. And then a lot of people tried to list the most common complaints that brought patients to the emergency department, and every study was very different. But things that came out were falls or injury, altered mental status, fluid and electrolyte imbalances, infection, immobility, and medication side effects. So after the scoping review, our group prioritized these following questions. How can we best evaluate in a patient-centric and care partner-centric manner the impact of ED interventions for persons living with dementia? And I think that's really key, is the patient-centric and care partner-centric, because some of those other studies I said we couldn't necessarily recommend, and we had a lot of discussion about whether we should or should not recommend the pain AD scale, but it was it wasn't clear that it was improving anything necessarily for the patients or the care partners. We think it probably is because we're documenting and identifying pain a little bit better. But I think this is the key is what are we doing for the patient and the care partner, not necessarily what are we doing for the processes. Which environmental, operational, personnel, system, or policy changes best improve emergency department care for persons living with dementia? You'll see that all of these questions are still quite broad because the landscape is still broad and still much needs to be done. I think an important one, how can gaps in training and dementia care competencies among clinical and importantly non-clinical staff be addressed in ways that achieve sustainable improvements in care delivery for persons living with dementia? Something I hadn't thought about before this process is the front desk at the hospital or security at the hospital, and how do they address persons living with dementia who are confused in the wrong spot? It can be anybody in the hospital that needs to really be aware, and how do we then reach these employees and staff members, in addition to the clinicians that I think that I was more in tune to thinking about initially. What economic or other implementation science measures address viability of optimal ED care practices for persons living with dementia? So I think that it's important, like we can sit in these rooms, we can have these conversations, we can come up with great ideas, and then try to implement them, and then they're around for 3 months and they fizzle and die. And so I think that it's really important to be thinking about the economic nudges, and incentives on how do we make these continue and last, and then other implementation science measures to figure out again how do we make processes stick once we develop them. And then how do various community and identity-based factors, including cognitive impairment, but also social determinants of health, impact delivery and receipt of ED care for persons living with dementia? And as Chris mentioned, the research out there, I think in all of our work groups, is severely lacking in description of demographics and race, gender, et cetera, and then also different community groups as well, and how different community groups might be perceiving and receiving care in the emergency department, with or without dementia even. So the care partners and persons living with dementia prioritize things a little bit differently. So they moved up the environmental, operational, personnel, system, or policy changes to best improve care for persons living with dementia. So they really they really want to know how do we improve care. I think that they were really saying that things are not great. We really want to improve things. And then how do various community and identity-based factors, including cognitive impairment, social determinants of health, impact delivery and receipt of ED care for persons living with dementia? So they thought that was even more important than the clinicians did. So that's our work group. I think that the overall message is that there's just a lot of work to be done. I'm really proud to be a part of the Gear 2.0 and to see some of the applications that came through previously, and hoping to see great applications coming forward, because I think there's a lot of work to be done and a lot of improvement that can be made. Thank you.
All right, I'm going to haven't had to deal with these mics in a while since we spent most of our time staring at monitors, kind of like I'm doing here. What's that?
The mute is still on.
You're funny. All right, so I'm Manish Shah at Wisconsin, and I'm going to spend a few minutes talking about the care transitions work that we did, and then leave a few minutes for questions after that. None of my conflicts have really anything to do with this. This is our team. The one cool thing that we didn't really mention here is we had a librarian core working with us on all this, and that actually made this much easier because I very rapidly realized I have no idea how to do a lit search compared to the librarians, and so they were absolutely critical for us. So for care transitions, one of the first things that we did is we brainstormed really what's our question about, and we took a very practical approach, and we actually went full out and just said we're going to talk only about cognitive impairment regardless of where the cognitive impairment comes from, whether it's delirium, whether it's dementia, or whatever. And we also decided we were going to concentrate on the ED to home component because you could be looking at many, many different transitions, and we really wanted to narrow this down. We then came up with the PICO questions, did the lit searches, abstracted the articles, and developed the preliminary research gaps as all the other groups did. When it came down to, we really drilled down to two main PICO questions that we were interested in. And the first was what interventions delivered to ED patients with impaired cognition and their care partners improve discharge transition? And what measures of quality ED discharge transitions are important to varying groups of ED patients with impaired cognition and their care partners? And it was actually really interesting. We had a lot of fascinating conversations about the second one here, even among the people living with dementia and care partners that were on our group, because a lot of them were just like, well, what's important to me? Why does this matter? And they're very, very eloquent in their conversation about this. We had a little bit of an easier time. We only had about 3,900 articles once we took the duplicates out, and it drilled down to a total of 10 articles for full abstraction. We only did one search process because the two were so closely related. We figured that we would just do this as one big search process. So of the 10 that we had, there were 7 that were tied to PICO 1 and 3 that were tied to PICO 2. And there were a couple of interesting things that we got out of this. First of all, none of the articles that included people that were cognitively impaired and cognitively unimpaired actually separately analyzed the cognitively impaired patients, which would seem like a pretty fundamental thing to do if 75%, as in one of the papers, of your patients were cognitively impaired. 2 of the studies actually focused on cognitively impaired patients fully. And what was interesting is that they showed up to a 75% decrease in ED visits within 30 days by an intervention. The further interesting thing is that for the PICO 2, there were only a couple of articles you see there. They mentioned lots of different potential measures as important, but none of them talked about ED revisits as being important, which led to an interesting series of conversations about, are we going down the wrong path? We went through and talked about the priorities, what are important. I'm not going to read through these here, but they were thought through and then taken to the overall consensus group. And then we ended up having 5 overall research priorities that were ordered from the voting during the consensus group. Number 1 being what improves outcomes of ED to community care transitions. Number 2 is what matters most to ED patients with impaired cognition, their care partners. And then moving on into barriers, facilitators. How can care partners and community organizations be engaged to improve these? And how can communication quality surrounding ED to community care transitions be optimally measured? This was our one piece where we kind of strayed a little bit into Chris's realm, but everyone felt it was pretty important during the communications group. What's great about this then is obviously these become the foundation, both our care transitions, but as well as the ones from the other 3 groups for the grant RFAs that came out. The first one the first one came out and it's going through the kind of study section process right now, and then there'll be 2 more rounds of this in the next couple of years. And clearly from all 4 of these domains, you can tell that there's a lot of work to be done, and that's why NIA was so set on saying, hey, we're willing to fund this at a pretty high amount. It's why EMF and West Health were both willing to contribute and participate in this so that we can jumpstart research in this area, lead to other NIH funding, and grow really this area much the same way we've grown the general geriatric emergency medicine research over the last 20 years. And with that, I'm going to say 2 things. First of all, Eula, were you going to do this, or did you want me to finish this out? Okay, I'm going to finish out. If you go to gearnetwork.org, you can see a lot of what we're talking about here. I know we've gone through a lot here over the last 40 minutes or so. The papers will be coming out in Journal of American Medical Directors Association, and so that's also going to be posted on the Gear Network site because we've purchased full open access. Talking a little bit about the funding opportunities from GEAR, this is the website for the funding opportunities that we're going to be doing. Watch for the release in probably summer, early fall for the next round. There's going to be an LOI process, and then the deadline will follow the EMF deadline. We are going to, and we did last time, a number of webinars to talk about the research priorities, give people guidance to prepare the applications, and also talking a little bit about the intersection between emergency care and people living with dementia. Eula mentioned the cores that we have for the folks that get the grants, and that's a core component of people that are the grantees. They'll be participating in work with the cores to help do better research with people living with dementia, as well as get advice and feedback on their research through research in progress type meetings. And so the overall opportunity has a great deal of support tied to that, such that it can really empower folks to go forward and get the separate NIH funding. And then on top of it, don't forget that there are a number of other funding opportunities out there, whether it's NIA, DOJ, ClinStar, GEMSTAR. Impact has a lot of money, and they're doing a lot of really cool things. We're working very closely with them. And then there are foundations out there. The other really important thing is that it's the team behind the scenes. And this has been a lot of work. And honestly, it's these folks that did a lot of it. We've had lead folks at a number of our sites, as well as folks that Connor and Laura from the JEDC group, who have been helping us a great deal to be able to pull this together, and we would never have gotten there without them. So we have to particularly thank all of them. And at that, we'll take questions. I think we have a few minutes here before we're supposed to be done. 5 minutes. We have 5 minutes. Go ahead. All right, I'm going to repeat them. I think there are about 5 questions there. So question number 1 was, how many people living with dementia and care partners were part of the overall group? Eula, do you remember? It's like 8.
Yeah, we had actually at least 8 persons living with dementia participate as part of the task force. Of course, some had to drop out, over the course of the years. But even at the conference itself, though, we had 5. And that's just the individuals who have a diagnosis of cognitive impairment, dementia, some disorder. And then we also had care partners. And with the work groups, there was at least a representation of one of each in each of the work groups. So we really wanted to make sure that they were front and center and represented in best ways possible. One of the things we didn't mention on here is we also have a health equity advisory board that we've created. This was not in the original proposal. This was more, we had an advisory plan during the second phase, but I think really recognizing the importance of representation, that Health Equity Advisory Board, we have individuals, we've tried to bring in as much representation as possible, but we have individuals there also who have dementia and their care partners. That's the first question.
So it worked out to about, maybe almost about 15% of the overall group. So it was a pretty hefty group. In terms of, we did a lot of presentation of this is what the care partners and the people living with dementia wanted, and this is what everybody else talked about. We did the synthesis of this a couple of different ways, and ultimately everyone wanted almost the same thing. It wasn't like they were horribly discordant. And when the discussions occurred, particularly at the consensus conference, at that point, the views and the perspectives of the people living with dementia and their care partners really came front and center. And I think that really reflected the perspective of everyone that was there. It was not this, we are biomedical and therefore that's all we care about perspective. You want to add to that?
Yeah. So I really want to highlight what Manish brought up is I think the richness of the consensus conference, it was exhausting. It was like almost 8-hour days, 2 days. But everyone, we got so much feedback afterwards. People were, I would say, almost 100% engaged both days. And what they loved the most were these discussions because they learned from each other. It's that opportunity to hear the other person's perspective, the patient's perspective and the care partner's perspective. And so I don't think there's often an opportunity where we do that, and we don't take the time often to do that. And so that was, I think, what really that was the strength behind this.
And the piece I'm going to add, we actually had to do a lot, and we worked with a group called Live Well that has a lot of expertise in this, to actually prepare the people living with dementia to participate in this. And it worked incredibly well. And we did a similar thing. We actually just did this last week. We had a community review committee, which seems redundant, for reviewing the grants that were submitted. And we actually had 5 individuals that were either living with dementia or their care partners on this committee to review the grants. And we did that this week. And they did an incredible job with the proper preparation. And so the footprint of this key stakeholder group is very heavy within the GEAR 2.0 structure.
And the ratings agree with the Scientific Review Committee.
Yeah, and their ratings did agree with the Scientific Review Committee. We can't talk about it right now because we still have to get it through the various approval processes, but we were really kind of excited. The Scientific Review and the Community Review were exactly the same. I know I'm forgetting a couple questions. My impaired cognition's still here. So, other questions? I guess in wrap up, I just want to say, and I'm going to let everyone else have a quick final statement, but watch for these RFAs coming out because these are really great opportunities for us in the field. It's no different than the GEMSTAR, the Janigan, and all those initial small ones that we had that have been so successful leading to bigger grants. So watch for these over the next couple of years and encourage folks at your sites to apply for them so that we can really grow this area of research. Chris?
Yeah, I've been focused on this dementia population for a long time, and we finally made some inroads to the NIH where they recognize that we can do research on persons living with dementia in the ED. I think there's going to be more funding opportunities available. I'm very confident to that. Make sure that as you're designing your research in whatever area you're in, you're considering this population of persons living with dementia. If we actually screen this population over age 65 coming through our EDs, about 30% of them are going to have an abnormal cognitive assessment. Doesn't mean they have dementia, and as you all know, dementia comes in various severities, so it's not a monolithic disease process. But do consider these populations, and we also have a separate effort going on developing an update to the Geriatric ED guidelines that are the basis of the ACEP accreditation process. We need your help, and we do have a dementia working group right now, so if you're particularly interested in this area, please come talk to us and get involved with updating the guidelines. We're looking at delirium as well as falls and elder abuse. We're going to have a transitions of care, so there's lots of work to be done.
Thank you. Final comment, I'm just going to encourage, Scott, I'll have a comment, but I wanted to really encourage everyone just keep checking the website, the GEAR website. We're going to be updating it, and we are going to be trying to move forward with more webinars and core support groups. This, for those of you who are like, well, how do I break into this area of research? That's what these webinars are going to be focused on. That's what some of these office hours and that's what the core is meant to do, to help sort of guide you in your area of interest and how does it now weave and intersect with emergency care for persons living with dementia and geriatrics.
And I echo all that. I'm really excited for the whole process. I also want to say, if anybody here is not a member of AGEM, please join AGEM. Just got to put that plug out there. But in all seriousness, so it is it's part of your SAEM membership. So just click the button. But I'm really honored actually to be here with. We just named 4 of our pioneers in geriatric emergency medicine, and I'm standing next to 3 of them. And I think that something that we've done well in AGEM is help bring people up and help to support and mentor and that sort of thing. And I've really benefited from the mentorship of these 3 people here and many others within AGEM. And so be part of this community, be part of this research. There's a lot of work that needs to be done. There's a lot of opportunities, and thank you very much.